Bueno, buenos días o buenas tardes. Estamos justo en el mediodía de Uruguay, así que cualquiera de las dos opciones son buenas. Quiero darle la bienvenida, a todos los participantes del Congreso, que por razones de la pandemia estamos en virtualidad. Es un poco extraño esto, no tengo a nadie enfrente, algunos amigos, pero pocos. Y darle las gracias fundamentalmente a Laurent, al doctor Brochard, por compartir con nosotros toda su experiencia, toda su expertise y toda su calidad humana. Esperemos tenerte pronto por Uruguay en forma presencial, Laurent, pero la realidad de hoy es que tenemos que estar a kilómetros de distancia y tenerte, por suerte, y compartirte en forma online. El doctor Brochard nos va a dar una conferencia sobre el manejo de la injuria pulmonar asimétrica. Para los que no lo conocen, el doctor Brochard es un referente en el área de cuidado respiratorio crítico pulmonar. Él es un intensivista, es director de la División Interdepartamental de Cuidados Intensivos de la Universidad de Toronto, es profesor titular de la División de Cuidados Intensivos del Hospital Saint-Michel en Toronto, Canadá. Su formación se formó en Francia, nosotros lo seguimos desde los inicios. Estuvo una pasantía por Suiza, unos años trabajando en Suiza, y ahora está definitivamente en Toronto. Pero es un lujo tener al doctor Brochard con nosotros, así que bienvenido, y te dejo, Laurent, con tu presentación. Gracias.
Okay, muchas gracias and merci. Thank you very much for the invitation. So that's really a pleasure, and sorry not to be with you face to face, but we'll take benefit of the Zoom technology to be together. So my presentation this morning will be about I think a frequent clinical problem in the ICU, which is how to best manage asymmetrical lung injury, and are the recommendations we usually have for ARDS, for instance, how do they apply for these patients? So I've been working with a number of companies to get research grants or equipment, and they are listed here. And the classical presentation of ARDS is bilateral and plus or minus symmetrical, right? So we think of ARDS as a diffuse inflammation, therefore the two lungs are injured, and maybe even if there may be slight difference, you think that in most of the case it's bilateral. However, when we look at CT scan, for instance, we see sometimes much more heterogeneity than what we thought. And there are patients who are really clearly asymmetrical, even if it's bilateral. So maybe it could be called ARDS. And I don't think it matters too much how we call it, but it's clearly asymmetrical, as illustrated on the X-ray and also on the CT scan. And I'm not sure we know very well how to manage these patients, which maybe are very, very frequent. So if you look at the literature about asymmetrical lung injury, in fact, you see mostly data in patients with unilateral lung injury. And as I described before, it's much more frequent to have asymmetrical than purely unilateral, which exists also, right? And one of the things which has been studied the most is the lateral position. So for the lateral position, you try to put the bad lung up, so the compliance of the chest wall will be increased, and it will be easier to reopen the bad lung. And you put the good lung down because you think there will be more perfusion going into the ventilated area. And this is probably the explanation why in most of the case you see benefit in terms of oxygenation. PEEP is beneficial, but however, we don't know how much PEEP we should give, and that's something I'm going to discuss a lot. And that's important because when you put the good lung down, maybe if you don't put enough PEEP, you may have progressive atelectasis occurring in the healthy lung, which is put down. Some studies, but that's in small animal models, so it's difficult to extrapolate to humans, have shown that PEEP seems to be important and seems to have beneficial effect on inflammation in the injured lung without deleterious effect on the non-injured lung. So this was a unilateral lung acid instillation, a very specific model. And you see here the IL-6 as an indicator of inflammation, going down with PEEP in the injured lung, but do not going up in the non-injured lung, so suggesting that PEEP seems to be beneficial. And that's really difficult to understand for a clinician, because we are always afraid of hyperinflating the good lung and not doing something to the bad lung. So let me show data. This is experimental data. This is in pigs with lung injury, so it looks more like a very recruitable model. But let me first start with bilateral lung injury, just to put in your mind something about the difference between what we see on the global lung and what's happening regionally. There is a technique which is called electric impedance tomography, which can give regional ventilation. So if you have regional ventilation, you can measure the pressure and the regional ventilation and measure the regional compliance. And in this study, we measured the compliance of the dependent lung. So the lung, again, this is bilateral lung injury. The animals are supine. So this is the lung which is down, the part of the lung which is down. And the black dots is the compliance in the non-dependent lung. So the lung which is closer to the sternum and which is more at risk of hyperinflation. And if you look at the third curve is a global compliance. So the one we see at the bedside if we measure compliance. And so think of this animal with bilateral lung injury. If you think, for instance, that the best PEEP should be the best compliance for the dependent lung, so the lung which is really with all the atelectasis and condensation, well, you need to go in this model to 15 of PEEP. And this is also what would indicate the global compliance. But if you look at the non-dependent lung, half of the lung, the best PEEP is only 8, which means that every time you go above 8, you start to over-distend the dependent part. And in this study, we showed that prone position was a fantastic tool because in this situation, the distribution of the ventilation is much more homogeneous, and you see the best PEEP is almost the same for the two parts of the lung. So I think this concept is important when we are going to discuss asymmetrical lung injury, because the question is, when we set a PEEP for the whole respiratory system, how does it work for one lung versus the other? And we did another study with Luca Bastia, who came from Milan to work in Toronto. And again, using this technique, the electrical impedance tomography, to assess the regional ventilation in different quadrants of the lung, if you wish, which are defined as region of interest. And in this model, what Luca tried to do is to create an asymmetrical lung injury. In fact, he wanted to create unilateral lung injury by blocking one lung and creating injury in the other, but it was not possible. There was also some injury in the other lung. And in fact, this is the PV curves. The black one is before the injury, the white one is after the injury. And you see, after the injury, one lung was very injured, so the PV curve is much worse. The other lung is not completely normal. So we really created a model of asymmetrical lung injury, as illustrated on the CT scan. So the question for us was, okay, how is distributed ventilation and how should we set PEEP in this model? So we add an esophageal catheter, which is a technique which can be used at the bedside in the ICU. And that's a technique which I strongly support and recommend for monitoring. And you will see that there are very interesting results about esophageal pressure in this study. So having the esophageal pressure, for instance, you can calculate the transpulmonary pressure, which is the distending pressure. It's simply airway pressure minus esophageal pressure. And one thing which was interesting was that we also measured the regional pleural pressure, and it was the same everywhere. So that's interesting because when you measure esophageal pressure, it's valid because the two lungs will be submitted to the same esophageal pressure. And when you look at the injured lung, the non-injured lung, you see that so the PEEP level is from 0 to 20. It goes up, it goes down, so the transpulmonary pressure and the driving pressure, which is shown on the next slide, show the same. It goes down with some PEEP, and then it goes up if you put maybe 2 more PEEP. And I'm showing what is called the end expiratory transpulmonary pressure. This is the technique which has been described in ARDS to titrate the PEEP to make the end expiratory transpulmonary pressure, so the difference between PEEP and esophageal pressure, close to 0. And it was interesting that the best driving pressure, so for each lung, and that was similar for each lung, was about the time where the end expiratory transpulmonary pressure was 0. So you could say maybe at the bedside in patient with asymmetrical lung injury, trying to reach a target of 0 transpulmonary pressure may be useful for the patient. We looked at the distribution of ventilation between the two lungs, and this was possible with EIT. And this is very interesting because it made us think really about what we do with PEEP. So you see at 0 PEEP, in this model, 70% of the tidal volume was going into the non-injured lung and only 30% to the injured lung. So that's what you expect with something asymmetrical, right? Most of the ventilation go to the normal lung or less injured lung. And when you increase PEEP, this distribution becomes more even. And you see even at 20 of PEEP, now you have 50-50 distribution of ventilation. Is that good? Well, not necessarily, because the way PEEP is working is, let's say first, when you go from 0 PEEP to 10 of PEEP, the main effect is to decrease the collapse in both lungs. So to reopen the recruitable lung, which is good. But then when you continue to increase from 10 to 20, the main effect is over distension of the LC lung. So this is how you redistribute ventilation, not by continuing to reopen the bad lung, but by over distending the good lung. So it means, well, there is a sweet spot for the right PEEP. You absolutely need some PEEP to recruit the bad lung, but if you put too much PEEP, you will simply over distend the good lung and put ventilation in the bad lung. This is the regional tidal ventilation. It's indicating the same thing. You see that above a certain level of PEEP, you start to over distend the other lung. And as I told you before, this is approximately where the transpulmonary pressure is about 0. So if you look at the regional compliance, this is the same concept, right? the injured lung has a compliance which is maybe optimal around 10, whereas the other lung has a optimal compliance for higher PEEP, but the price to pay is to distend the other lung. So the conclusion are that PEEP is necessary to redistribute tidal volume, but that excessive PEEP will distend the non-injured and also the injured lung. Esophageal and transpiratory pressure are reliable tool in this condition, and optimal driving transpiratory pressure may be a good indicator for PEEP titration with end expiratory transpiratory pressure equal to 0. So these data are very interesting because they tell us that PEEP is really useful and necessary, but we should be careful not going too high, and esophageal pressure may help us to find the good spot. Okay, let me make things a little bit more complicated. There is a phenomenon which we describe in patients with ARDS, which we call airway closure. So what is it? It's something which for many years we interpreted as being the reopening of a collapsed lung. And this is not exactly the same thing. So this is a pressure volume curve who would be performed in a patient. We start from 5 of PEEP and you see the increase in volume and pressure. And the slope, as you know, of this curve is called the compliance of the respiratory system. In some patients, for instance, you start at 5 or even here slightly higher. The initial part of the curve is almost flat. I say almost because you still see some increase. But what we put here, the red dashed curve, it is the compliance of the tubings of the ventilator. If you just take the ventilator circuit, you insufflate it, this is what you find. Which means that in these patients, until you reach 15 or 16 centimeters of water, you do not insufflate the lung at all. And this is not because the lung is completely collapsed. This is because the airways, somewhere in the lung, we don't know where, are closed. It's a bit mysterious, but you know, it's a natural phenomenon. This is why, for instance, we always keep some residual volume in our lungs if we want to expire, our airway close, and so we always keep some volume. But in ARDS, it can happen at much higher pressure than 0, and sometimes up to 20 or even higher. With Adrien Rosé in Bordeaux, we did a study in patients with asymmetrical ARDS. So this group of investigators is seeing a lot of asymmetrical lung injury because it's a surgical unit and they have patients with some local injury or lung resection. But it's also some patients with COVID and so different types of patients. Quite severe patients. Then what he did was during the after the OR, he used something to block each lung to do a PV curve of each lung. So he knew the lung were very asymmetrical. And what he found is when you do the PV curve of, for instance, the left lung, maybe you see a little bit of airway closure, maybe at 3 centimeters of water on the left lung. But this is what he found on the right lung. The airway closure was much higher on this lung, maybe around 18 centimeters of water. So the two lungs were very different. But when you look at the global curve, it is much closer to the healthy lung. So it does not tell you what's happened in the bad lung. And then what he did in this study was to validate the technique, which is a technique very complicated to use in the ICU. You can use in the OR, but in the ICU it's complicated. He validated using EIT. He said, okay, I don't need to block each lung. I just do a pressure volume curve, but I look at the behavior of the left lung and the right lung just with this technique of EIT. And he found the same behavior. And then he described a series of patients who really looked asymmetrical and who could have, so again, using the electrical impedance tomography, who could have this kind of global PV curve. And you see it looks like the classical, what we describe as the inflection point. But when you look at the global PV curve and is separated between the right lung and the left lung, he saw that the level of pressure to reopen each lung was very different. And the global PV curve was very influenced again by the healthier lung. So just to show that this is what he found, this is the what we call the airway opening pressure, so the pressure at which the PV curve change with each side, and he found that the global PV curve was close to the best curve. So the conclusion was that in these patients with asymmetrical lung injury, you could have airway closure and airway opening pressure at very different value in each lung. The inflection of the global PV curve reflects the less injured lung, and a higher PEEP than the inflection may be required to keep all airways open and lung ventilated. So this is, as I said, makes things a little bit more complicated because we didn't have, for instance, in this study, the esophageal pressure to see whether the transpulmonary pressure at any expiration would be the best technique. But the notion is that looking at the global PV curve may not be a good indicator. It certainly indicates the lowest PEEP you need, but to reopen the other lung, you may need to have a higher PEEP based on the regional behavior of each lung. And then you may be, the trouble may be that if you use a higher PEEP for that lung, you may have to go to a higher PEEP and higher plateau pressure, and therefore need to reduce the tidal ventilation. So I would say the conclusion is that these patients are really very difficult and complicated. I think that PEEP is still very important, so we should not go for the lowest possible PEEP. That PEEP is really needed to re-equilibrate the two lungs, but that excessive PEEP will distend one lung versus the other. And for now, I think looking at the esophageal pressure is one technique which could be recommended because it's, I think it's feasible. It's not very complicated. You can use a monitor, a cardiovascular monitor, and put the esophageal pressure. So you could look for the ideal transpulmonary pressure close to zero. And ideally, the best technique should be to have electrical impedance tomography, which I know is not available everywhere. But this is a technique which really brings something, telling you how the ventilation is distributed in the two lungs, and which can have an important impact on the way we ventilate patients, and which can be used to avoid unnecessary high pressure in the patients. I'll stop there, and maybe we'll be happy to take any questions. I put the website coemv.ca, which is a blog, Center of Excellence in Mechanical Ventilation, where we have also an open forum for discussion and where we discuss all this complex physiology for the bedside. Thank you very much.
Gracias, Laurent. Excelente presentación. Realmente, nos ilustraste con un montón de conceptos que obviamente la tomografía de impedancia ayuda a esclarecer. La patología asimétrica es un gran desafío. Obviamente que el distrés también es una patología asimétrica en sí mismo, porque las áreas dependiente y no dependiente tienen ese comportamiento que tú mostraste en el pulmón izquierdo y derecho cuando la patología es asimétrica. Pero se hace difícil ventilar el distrés, mucho más difícil es ventilar el distrés cuando él es asimétrico. ¿Hay alguna pregunta del auditorio? Por ahora no estoy viendo, pero yo te quería hacer un par de preguntas, Laurent. La primera pregunta, te las hago juntas y tú después ves cómo me las respondes. La primera pregunta es ¿qué opinión tienes o te merece la ventilación en decúbito lateral, que lo mostraste al principio de tu presentación? Si ustedes hacen en la práctica clínica ventilación en decúbito lateral. Y la segunda pregunta, dado que la tomografía, recién nosotros estamos empezando a trabajar con tomografía de impedancia, algunos centros, y todavía no está disponible en Uruguay, y el balón esofágico también tenemos experiencia, pero tampoco es una cosa que esté disponible en todas las unidades de terapia intensiva. Y además también genera una medida global, si bien es mejor que las medidas globales de compliance en el monitor del respirador, tampoco lo tenemos disponible. Entonces, te quería preguntar cuál es la medida, o mejor dicho, ¿tenemos que colocar a los pacientes en prono? ¿El prono tendría que ser algo más precoz en la patología asimétrica? Esas es quizás las dos preguntas que te quería hacer.
Okay, thank you very much. That's very important questions. So, the lateral position, it's interesting because there have been many studies showing, yes, you can improve oxygenation, but there is no real recommendation because for different reasons why these studies were mostly physiological, so there is nothing about outcome. And also there are clear evidence that it can be risky to put the patient on the lateral position, especially if you have a lot of, if it's very asymmetrical. And it's risky because you can induce atelectasis in the healthy lung. There was a recent experimental study which showed that very nicely. So if you put the healthy lung down, and if you wait for a sufficient time, you will create atelectasis in the healthy lung, which of course you do not want. So the point may be to use sufficient PEEP to make sure that you do not de-recruit the healthy lung. And so I don't think we can recommend to keep the patient for a very long time. One study which has been done recently by Roldan in Lima in Peru, and I had the pleasure to participate, was to put the patient with in each lateral position for 30 minutes. So patient was supine, then one lateral position for 30 minutes, back to supine, and then the other lateral position. And he used this as a way to recruit each lung separately. However, he was very careful to be sure that there is sufficient PEEP. So this was not unilateral lung injury, right? But so he used the recruitment to inflation ratio to say, okay, I use at least this level of PEEP based on the recruitability. Because if you keep the patient too long in one side and the PEEP is not sufficient, you will de-recruit this lung. So I think it can be used as a kind of recruitment maneuver without additional pressure, but you need to keep sufficient PEEP, especially if it's very asymmetrical. Then for the clinical aspect, I think, yes, electrical impedance tomography seems to be great, but it's not available everywhere. But really, I would say it can open your eyes on what we are doing regionally. So the good news with the experimental study about esophageal pressure is that the esophageal pressure, the pleural pressure was exactly the same around the two lungs. So, you know, there is a gradient from the top to down, but it was the same in both parts. So if you use esophageal pressure, it's still valid because it's the same pleural pressure for both lungs. Of course, to really know what's happening, this is where EIT is interesting because it gives you the regional volume. So with the regional volume plus the pleural pressure, you have all the information. But that's why esophageal pressure is still valid in this situation. And if you don't have EIT, that would be my recommendation to use it. And again, for instance, very simply to titrate P based on being as close as possible to zero and expiratory transpiratory pressure.
Muchas gracias, Lauren. Estamos en tiempo, así que vamos, en la tarde tenemos una mesa contigo, así que vamos a ver otros aspectos, ventilación espontánea, sincronías, y vamos a estar reuniéndonos de nuevo contigo. Un abrazo y muchas gracias.